The most important change in your intimate life after 60 may not begin in the bedroom. It may begin in a prescription bottle. It may begin with poor sleep, untreated pain, rising blood sugar, a heart condition, anxiety, or a conversation neither partner knows how to start. That is why one of the most damaging sentences an older adult can say is, "It is probably just my age." Sometimes age is part of the explanation. Bodies do change. Responses can become slower. Comfort may require more time and care. But age should never be used as a blanket answer for a new symptom. Persistent pain, repeated erection difficulty, bleeding, or a sudden loss of desire. Because when a real change is dismissed as inevitable, a treatable problem can remain hidden. And while the physical issue goes untreated, something else begins to happen. One partner feels ashamed. The other feels rejected. Affection becomes tense. Silence starts filling in the missing details. By the end of this video, you will know which changes can happen naturally after 60, which ones deserve medical attention, why the medicine cabinet may matter more than you think, and the one conversation that can stop a physical symptom from turning into an emotional distance. There is also one safety warning involving heart medicine and certain enhancement products that every older adult should hear. This video is educational and is not a diagnosis. Personal symptoms, medicines, and heart conditions should be discussed with a qualified health professional. Now, imagine a couple named Robert and Elaine. They are not real patients. Their story combines situations that many clinicians hear from older adults. Robert is 68. Elaine is 66. They have been married for more than 4 decades. For most of their marriage, affection felt effortless. A hand on the shoulder meant warmth. A kiss in the kitchen meant closeness. Neither person had to wonder what the other was thinking. Then Robert began staying awake after Elaine went to bed. He checked doors that were already locked. He watched television programs he did not care about. He found small jobs in the kitchen and told himself he would come to bed in a few minutes. Elaine noticed. At first, she assumed he was tired. Then she noticed that he was also avoiding long hugs, playful touches, and quiet moments that might lead to intimacy. She began telling herself a story. Maybe he no longer found her attractive. Robert was telling himself a different story. Several times, he had struggled to maintain an erection. The more he worried about it, the harder it became to relax. He did not want Elaine to see him as weak, so he avoided any moment in which she might expect more. Neither of them had stopped loving the other. But without one honest conversation, Robert's fear looked exactly like rejection. Months later, during a routine appointment, Robert finally mentioned the problem. He expected a joke, a quick prescription, or a dismissive comment about aging. Instead, the clinician asked a much better question. What changed before this changed? That question can uncover more than asking whether a person is still sexually active. What changed in the weeks or months before the symptom appeared? Was there a new medicine? A change in dose? A surgery? A period of grief? More alcohol? Less exercise? New pain? Poor sleep? A frightening episode of chest discomfort? A conflict in the relationship? The timeline matters because intimacy is not controlled by one organ. It depends on blood flow, nerves, hormones, physical comfort, energy, mood, trust, and the ability to feel safe enough to be present. The first thing many clinicians wish older adults knew is simple. Slower does not mean broken. After menopause, lower estrogen levels can make vaginal tissue thinner, drier, and less elastic. Natural lubrication may take longer, and some forms of intimacy may become uncomfortable or painful. For men, erections may take more time, feel less firm, or require more direct stimulation than they once did. An occasional difficulty does not automatically mean there is a disease, but couples often respond to these changes using the expectations of a younger body. They keep the same pace. They expect the same response. Then one partner starts monitoring every sensation, while the other starts reading every pause as a sign of lost attraction. The intimate moment stops feeling like connection and starts feeling like an examination. Robert's first mistake was not that his body changed. It was believing he had to hide the change until he could perform exactly as he had before. Elaine's mistake was not noticing the distance. It was assuming she already knew what the distance meant. A healthier response begins by removing the test. Closeness after 60 does not have to follow one script. It can include affection, kissing, massage, touch, conversation, or sexual activity that does not depend on one particular physical response. This is not settling for less. It is adapting intimacy to the body and relationship that exist now, rather than forcing both people to imitate the past. For vaginal dryness, a non-prescription vaginal moisturizer used regularly may help some people, while a lubricant used during sexual activity may reduce friction. A clinician can also discuss prescription options when appropriate, but pain should not be pushed through. Frequent or severe pain, burning, itching, bleeding after intimacy, sores, unusual discharge, or recurring urinary symptoms deserve medical evaluation. Menopause-related changes are common, but infection, skin conditions, pelvic floor problems, and other gynecologic issues can produce similar symptoms. The same rule applies to repeated erection difficulty. It is common, it is not shameful, and it should not be diagnosed from a video. But when it occurs often, it deserves a conversation, because it may be connected to another health problem. This is where the story becomes more important than the symptom. An erection depends partly on healthy blood flow and nerve function. Diabetes, high blood pressure, atherosclerosis, hormone problems, nerve damage, some surgeries, emotional stress, and certain medicines can contribute to erectile dysfunction. That does not mean erectile difficulty proves someone has heart disease. It means the symptom can be useful information. The safest response is neither panic nor dismissal. It is evaluation. A clinician may review blood pressure, blood sugar, cardiovascular risk, medications, mental health, alcohol use, smoking, sleep, and other symptoms. The goal is not merely to restore one physical response. It is to understand what changed in the whole person. Robert's clinician noticed that his difficulty had appeared gradually, but had become much more frequent soon after 2 prescriptions were adjusted. That clue moved the conversation from shame to investigation. Some antidepressants, blood pressure medicines, diuretics, antihistamines, sedatives, hormone treatments, chemotherapy drugs, and pain medicines can affect desire or sexual function in some people. A necessary medicine is not automatically the enemy. It may be protecting the heart, controlling depression, reducing pain, or treating another serious condition. Stopping it suddenly can be dangerous. That is why the answer is not to skip doses or secretly reduce the amount. The answer is a medication review. Bring every prescription, over-the-counter medicine, sleep aid, vitamin, and supplement to the conversation. Include anything purchased online. Then ask, could any of these be affecting my intimate health, and are there safe alternatives or adjustments? Depending on the situation, a clinician may change the dose, alter the timing, switch medicines, treat the side effect, or decide that the current medicine remains the safest choice. Robert did not receive a miracle solution. His clinician reviewed his health, adjusted one medicine under supervision, and addressed several contributing factors. that is less dramatic than an online promise. It is also much safer. And this leads to the warning I mentioned earlier. The product most likely to lower your guard may be the one labeled natural. The United States Food and Drug Administration maintains warnings about sexual enhancement products found to contain hidden drug ingredients. Some are promoted as supplements, honey, chocolate, energy products, or herbal remedies. A label can say natural, even when the contents are not what the buyer expects. That becomes especially dangerous when a hidden ingredient interacts with prescription medicine. Drugs used to treat erectile dysfunction can cause a dangerous fall in blood pressure when combined with nitrate medicines used for chest pain, such as nitroglycerin. A person who knowingly receives an erectile dysfunction prescription can discuss this interaction with a clinician and pharmacist. A person taking an unregulated product with an undeclared ingredient may not realize there is anything to disclose. So never assume that a supplement is harmless because it is sold without a prescription, has positive reviews, or uses reassuring words on the package. Do not buy intimate health products from an unknown source and combine them with heart medicine. Ask a clinician or pharmacist before using them, and tell that professional exactly what you take. If you value health information that treats older adults with honesty rather than embarrassment, subscribe. These are the conversations people often need, but rarely hear explained with care. Now we need to answer a question that causes enormous fear after a heart diagnosis. Is intimacy safe for the heart? For many people whose cardiovascular condition is stable, sexual activity is generally considered safe. Serious cardiovascular events during sexual activity are uncommon because the activity is usually brief, but the words stable condition matter. Someone with unstable angina, severe or worsening symptoms, or a heart condition that has not been properly assessed should speak with a clinician before resuming sexual activity. After a heart attack, heart failure diagnosis, surgery, or other major event, do not rely on a neighbor's experience or a general internet rule. Recovery varies. A useful question for the appointment is, my partner and I would like to resume intimacy. Is my condition stable enough, and what symptoms should make us stop? That question is more useful than asking whether intimacy is simply allowed or forbidden. It creates a personal safety plan. During intimacy, stop and seek urgent medical help for severe chest pressure, fainting, severe shortness of breath, sudden weakness, or other symptoms that could signal an emergency. Do not try to prove that you can tolerate the discomfort. Intimacy is not a stress test. Even after Robert's medication was reviewed and his physical confidence began to return, something surprising happened. His marriage did not immediately feel close again. Elaine had spent months believing she was unwanted. Robert had spent months treating every affectionate moment as a possible failure. The original problem had changed, but the habits built around it remained. He still hesitated before touching her. She still protected herself by acting as though she did not care. This is what many couples never expect. Treating the body does not automatically erase the story the couple created while the symptom was hidden. Silence creates explanations, and the explanations people invent are often harsher than the truth. When one partner pulls away, the other may think, I am no longer attractive. When desire changes, someone may think, our relationship is dying. When pain begins, a person may endure it because saying stop feels like disappointing someone they love. When erections become unreliable, a man may avoid all affection because he fears every touch will become a test he cannot pass. Soon, the couple is not only avoiding sexual activity, they are avoiding warmth. The most useful conversation usually does not happen during an intimate moment. It happens earlier, when both people are clothed, calm, and not under pressure. Robert finally said, I care about being close to you. My body has been responding differently, and I was afraid you would see me differently." Elaine answered honestly, "I thought you were avoiding me because you no longer wanted me." Neither sentence fixed everything, but both sentences replaced a painful guess with something real. A person who feels pain might say, "I want closeness, but this has been uncomfortable. I need us to slow down while I get medical advice." Someone whose desire has changed might say, "I love you. My interest has changed, and I want to understand whether stress, health, or medication is involved." A partner who misses affection might say, "I miss touching you, but I do not want every touch to feel like a demand. Can we rebuild closeness without pressure?" These are not admissions of failure. They are instructions for caring for each other more accurately. A helpful response is not immediate advice. It is, "Thank you for telling me. We can slow down, and we can find out what is happening together." That response protects dignity and lowers anxiety. It also makes it easier to separate affection from performance. There is another assumption that needs to disappear. Age does not remove the need for sexual health protection. Pregnancy may no longer be a concern for many older adults, but sexually transmitted infections can still spread at any age. Many infections may have no obvious symptoms. With a new partner, talk about testing, protection, exclusivity, and health history. Correct condom use reduces the risk of many sexually transmitted infections, although it does not eliminate every risk. Ask a health professional which tests make sense based on your personal history and current sexual practices. This is not a reason to fear dating after 60. It is a reason to enter a new relationship with the same maturity you bring to every other part of your health. Consent also remains essential at every age. No spouse or partner is owed sexual activity. Pain, fatigue, grief, illness, trauma, medication effects, caregiving stress, and personal preference can all change what someone wants. When dementia or another cognitive condition affects memory, recognition, judgment, or the ability to communicate, questions about consent and safety can become complicated. Families and caregivers should seek guidance from qualified health and social care professionals rather than making casual assumptions. The purpose is not to take away dignity. It is to protect dignity, choice, and safety at the same time. So how do you know what to do when intimacy changes? Do not begin by asking, "Am I too old?" Begin with 4 better questions. First, what exactly changed? Was it desire, comfort, lubrication, erection, orgasm, energy, confidence, or emotional closeness? Vague worry is difficult to evaluate. A specific change gives you and a clinician somewhere to begin. Second, when did it change? Was the change sudden or gradual? Did it begin after a new medicine, dose adjustment, surgery, diagnosis, stressful event, or loss? The timing can reveal patterns that embarrassment hides. Third, is there a safety concern? Persistent pain, unexplained bleeding, sores, unusual discharge, a new lump or skin change, repeated erection difficulty, a painful new penile curve, or sudden symptoms should not be dismissed. Chest pressure, fainting, severe breathing difficulty, sudden weakness, or confusion may require emergency care. And fourth, what conversation is being avoided? Is someone guessing instead of asking? Is affection disappearing because it feels connected to an expectation? Is one person hiding pain? Is a partner afraid of discussing a medication or heart diagnosis? Sometimes the next right step is a medical appointment. Sometimes it is a medication review. Sometimes it is pelvic floor physical therapy, counseling, or a referral to a gynecologist, urologist, or other specialist. And sometimes the first step is a quiet conversation at the kitchen table. You do not need to know the perfect specialist before speaking up. A primary care clinician can often begin the evaluation and guide the next step. One sentence is enough. Something has changed in my intimate health, and I would like help understanding why. Clinicians may not always ask first. Appointments are short, and the conversation can feel uncomfortable on both sides. Bring a written note if saying the words feels difficult. You can also ask to speak privately. Your intimate health belongs in the same medical conversation as sleep, pain, blood pressure, mood, and medication. Robert and Elaine did not return to the way they were at 30. That was never the real goal. They learned to stop measuring closeness by one physical response. They made affection safe again. They allowed more time. Robert followed up on his broader health. Elaine spoke about the hurt she had hidden. Neither person had to pretend that the previous months had not affected them. They built something different from the past. Not younger, more honest. The body can change after 60 without becoming less worthy. Desire can change without love disappearing. A slower response is not the same as failure. A symptom may be common without being something you must silently endure. And a medical problem is not a moral problem. The most important truth many doctors wish older adults knew is that intimate health is still health. It can reveal changes in circulation, hormones, nerves, medication, mood, pain, and relationships. The moment a person stops saying, "It is only age," and starts asking, "What changed?" better options become possible. Before you leave, tell us which topic should be explained next, with the same respect. Medication side effects, heart safety, or menopause-related discomfort. And in the next video, we will look inside the medicine cabinet at the everyday prescriptions that can quietly affect desire, erection, lubrication, and orgasm. One of the most overlooked categories may already be sitting beside your bed. So before you blame your age, check what changed.